All right, good afternoon. Welcome to the final workshop of our Housing Equals Justice Conference. Richard Cho, the CEO of Connecticut Coalition and Homelessness. I hope many of you have been following along and enjoying our conference. This session is entitled Help Not Handcuffs, and it's about improving as well as reducing police responses to people experiencing behavioral health crises, including those experiencing homelessness. And I'm really excited about this. This is an issue that I think has become much more of concern as many communities are seeing many instances of negative outcomes when people with behavioral health crises become involved in police contact when police don't always have the training and the collaborations to respond. But what you're going to hear about today is some promising efforts that are happening here in Connecticut that are really looking to improve the way that police and behavioral health and other homeless service providers can work together on improving responses to people who experience mental health and substance use related crises. This is our 18th annual Training Institute and Conference on Homelessness. This year's theme is on Housing Equals Justice, really highlighting homelessness as an issue of economic justice, as an issue of racial justice, as well as an issue that relates to criminal justice. As COVID-19 has showed us, homelessness also is an issue of health equity and justice as well. So this session really is, I think, focused on how we can improve the way that criminal justice can work together with services to address homelessness. On the next slide, please join us and share what you're learning and hearing through this session and other sessions through social media. Help us tell the world that housing equals justice. Join us on Facebook, Twitter, Instagram. You can use a number of hashtags, ATI 2020. Hashtag housing equals justice and hashtag end homelessness. Also visit our store. We have a store where you can purchase and show your support for housing equals justice. You can purchase t-shirts, hoodies, face masks, and mugs. So if you go to our web page, the address is at the bottom of your screen there, and click on store, it'll bring you to our bonfire store, and the proceeds actually go to support over our efforts to end homelessness. With that, I want to just thank the presenting sponsors for our conference, Bank of America and Zillow, who made it possible for us to bring this conference to you free of charge and to make it available to the public. And I also want to thank the Connecticut Department of Mental Health and Addiction Services for being our workshop sponsor for both this session as well as another session we held on housing plus services. And so with that, I want to actually turn to Kim Karanda from the Department of Mental Health and Addiction Services.
Thank you very much, Richard. And I also want to extend thanks to your staff for an incredible week of learning. I have the great pleasure to introduce our panelists and our moderator for today. I'll start out with Susan Graham from the Connecticut Alliance to Benefit Law Enforcement, also known as CABLE. Susan is a national speaker, trainer, and coach, and holds a Master of Social Work and Master of Arts in Women's Studies degrees. She had a 20-year career as a police officer and has extensive experience conducting individual and group coaching, mentoring, and training. Ms. Graham is a youth mental health first aid instructor and the training coordinator at the Connecticut Alliance to Benefit Law Enforcement. Wanda Jofre is a licensed clinical social worker at the Community Mental Health Center in New Haven. She is a crisis intervention team clinician. CIT provides trained clinicians to work collaboratively with CIT trained officers, providing mental health evaluation and recommendations when responding to crisis calls. The goal of CIT is to reduce the need for arrest of individuals with behavioral health needs. Next, we have Nydia Rios-Benitez, who is a licensed professional counselor and the director of evidence-based practices and grants at DMHAS, Office of the Commissioner. Ms. Rios-Benitez has more than 25 years of experience managing a variety of clinical and community-based programs at the department. She is a powerful advocate for the incorporation of persons and families with lived experience being at the forefront of the state's recovery-oriented system of care and was the driving force of the Community Wellness and Recovery Coalition. Nydia manages crisis intervention team partnership programs between local police and the behavioral health provider network. Next, we have Sergeant Michael Fumiatti. Sergeant Fumiatti currently serves as the City of New Haven as the Fairhaven District Manager. He has spent the past 13 years working in a variety of environments, including hospitals and residential facilities, alongside medical and mental health professionals. In addition to these roles, he is also the New Haven Police Department Crisis Intervention Team Coordinator and officer in charge of the Elite Hostage and Crisis Negotiation Team. Sergeant Fumiatti is a certified police instructor in the state of Connecticut and teaches CIT and de-escalation statewide. And finally, we have our moderator for today, Attorney Brian Preleski from the Connecticut Division of Criminal Justice. Since 2011, Brian has served as state's attorney for the Judicial District of New Britain. Attorney Preleski has helped to lead efforts to reduce prosecution and incarceration among people with behavioral health needs, including those experiencing homelessness. He has been instrumental in launching the Heroin and Opioid Prevention and Education, aka the HOPE Initiative in New Britain. Please join me in a virtual welcome for our esteemed panel.
Thank you very much, Dr. Coranda. I am Brian Preleski. I'm going to be the moderator today, and as you heard, I'm the state's attorney here in New Britain. This is, for me and for everyone in law enforcement, and for everyone I think now in society, an incredibly important issue, because one of the things, and I've been doing this for 30 years, almost 30 years, one of the things that we know is that when we come in the morning to work, our docket is driven primarily by two things, and those are our mental health issues and substance abuse concerns. And trying to deal with those things is something that not just law enforcement needs to be concerned about, but all of our society needs to be concerned about. Because once an individual with a mental health issue or with substance abuse issues gets involved in the criminal justice system, there are a lot more things that have the potential to go wrong for that individual than there are that have the potential to go right for that individual. So what this, for me, is really about is how can we do this better? Not that we can do it perfectly, but let's look at what we're doing and then look at how can we do that better. And we have some great panelists today who I think you're going to really look forward to hearing from. If you do have questions, click on the Q&A button, and I will be monitoring that. And I will try to throw any of those questions out as appropriate. And our first person today who's going to be discussing some of the collaborations that DMHAS has relating to behavioral health crisis response, including mobile crisis and crisis intervention teams, is Nydia Rios-Benitez. So Nydia, please take it away.
Thank you so much. Thank you, Kim, for your beautiful words and for the introduction. First of all, I want to thank Richard for inviting me to this panel. Really appreciate it, and all the attendees for being here on a Friday afternoon before a holiday long weekend, which I know is not easy, but also after a long week of what clearly seems to be an intellectually enriching opportunity. So it's a pleasure to be here. And obviously, if we want to speak about less handcuffs and more services for all the individuals in Connecticut, including those that are homeless, it is important that we give you an overview of what we have here in Connecticut as a mobile crisis response service system. So that's what I'm going to talk to you about, and then you will get more information specifically on the work. So the Department of Mental Health and Addiction Services provides mobile emergency crisis services to those individuals that are age 18 and older. For younger individuals, DCF provides the services. Mobile emergency services are defined as mobile. They're readily accessible. They're rapid, they respond quickly, they're short-term services for individuals and families that are experiencing episodes of mental health or substance use crisis. Obviously, the crisis is defined by the individual. There's not a definition by anybody else. The person will know. In the state of Connecticut, we have a total of 18 mobile crisis teams in the state. 8 of them are DMHAS operated, 10 are DMHAS funded, and all of those mobile crisis teams offer persons in distress immediate access to a continuum of crisis response services of their choice. That includes mobile clinical services, family, peer, and community supports, and or mental health and addiction treatment. The teams aim to promote the prevention of crisis among people, but also to provide postvention activities that support persons in developing a meaningful sense of belonging in their community. And that is crucial for any person in crisis or not. Feeling a sense of citizenship, a sense of participation in your community and having a network is crucial and important. And that is a very, very important component of recovery. Mobile services, as the word says, and we cannot repeat enough, are mobile. They are available where the person is at physically and emotionally because they are person-centered. They respond to individuals, the mobile crisis team, located in the towns and city based on the DMHAS catchment area. So actually, I don't have any slides, but if you do go to the DMHAS website, you can find by areas the agencies that have mobile crisis team and the towns that they cover, but it's statewide. Despite the shared mission and goal of the mobile crisis teams, obviously they each function a little bit different. There are components of the teams that vary in terms of their hours of operation, the mobile outreach hours when they go out, the staffing patterns, the contact numbers, the after hours coverage, etc. They generally are composed of an array of mental health professionals, primarily master level and licensed clinicians, that including social worker, nurses, and in some cases, recovery supports or peers. The number of staff on the teams vary across the state. Some are smaller, some are larger, but all staff receive training in multiple areas, including obviously risk assessment and screening, for those that are social worker, emergency certificates training, and procedures. They all receive training in the crisis intervention teams, which is the work that Cable Sue is going to talk about. We ask all mobile crisis team staff to be trained on that. And most importantly, on de-escalation and engagement strategies. So the important thing here is that when a mobile crisis response person is servicing someone who's in distress, the most important thing is for them to be able to connect to that individual so they can actually offer the help and the assistance. The hours of operation, as I mentioned before, do vary. Most of them start at 8 o'clock in the morning, and some of them provide outreach until midnight. There are a couple of agencies that through a grant are going to be extending mobile hours to 24 hours. But currently, not all offer that, and not all operate during the weekends and the holiday. In the fiscal year 19, mobile crisis teams received over 5,000 adult crisis calls requesting assistance for persons in distress. Close to 90% of individuals served by a mobile crisis team did receive a referral to ongoing interventions or support. During fiscal year 20, the first 2 quarters, the statewide average for DMHAS outcome measure were as follows. Mobile crisis team were able to respond to 75% of the calls within 90 minutes of the initial request, which is what is expected in most model. 93% of the interventions were performed in community locations, which is what's expected too, that you go out and you're mobile, and 92 of the individuals served had follow-up services within 48 hours. In addition, in the first half of the year, the police have been involved in almost 2,000 mobile crisis calls in the community. Something very exciting that happened earlier this year, as of August 12th, DMHAS, in partnership with United Way of Connecticut, has launched a centralized crisis call center for adults in the community. So up until now, different mobile crisis teams had different numbers, and we had actually heard from the citizens in general that sometimes they didn't even know they had a mobile crisis team, let alone try to find the number to call. So now 211 has the action line, which is a centralized statewide line for adults in the community that are experiencing emotional crisis, which an immediate response may be required. It's the Adult Crisis Telephone Intervention and Options Network. That's where the action line acronym comes from. And we like to stress the option part because, again, this is person-centered. The action line is available 24 hours a day, 7 days a week, and is the provider of after-hours telephonic coverage for mobile crisis teams. The services that they provide include telephonic support, referral to the mobile crisis team in the area, information about resources, services, and if it's needed, direct connection to 911. The action line is targeted to be fully implemented statewide by December 2nd. We've been going on a stage-wise process, facing in different areas of the state. So by December 2nd, it will be statewide. And United Way has hired recovery support specialists or peer to be part of their team, which is also very exciting. Mobile crisis teams in general partner with family members and others as identified by individuals that are significant to them. They partner with peer-run and the recovery community organizations, the faith-based community, law enforcement, and other civic and community organizations to make sure that a person in distress and their loved ones have the support and the valued social roles within their local community. We want to go beyond the boundaries of the behavioral health system. The 18 mobile crisis team come together monthly in what we call the Mobile Crisis Response Learning Collaborative. And the purpose is to provide a forum for all mobile crisis teams to enhance their training, their education, to foster the adoption of person-centered, family-oriented, strength-based, and culturally competent practices that are going to help teams to connect individuals to the array of services and support in their local communities that they choose. Mobile crisis clinicians also collaborate with and assist local police officers to help de-escalate crisis and provide diversion to alternative settings rather than incarcerations. Since 2003, actually, DMHAS has contracted with the Connecticut Alliance to Benefit Law Enforcement, CABLE, to provide training on crisis intervention team model to clinicians and police officers. CIT, as we know it, Crisis Intervention Team, is a best practice designed to provide a collaborative and integrative approach that offers law enforcement the knowledge and resources to connect people who are experiencing behavioral health symptoms to supports and services that will best meet their needs and divert them from arrest and or incarceration. all of this while obviously promoting safety for the person in crisis, safety for the community, and for the officers that respond to the crisis call. So with the title of this workshop, obviously, we do want to reduce and improve, as Richard mentioned initially, the number of responses. The police obviously are not the first responder to a mental health or substance use crisis. However, in those situations in which they are involved, or for whatever reason, it is crucial and important that the police officers are trained as well as the clinicians are trained, and that both have developed a collaborative relationship. There are CIT trained clinicians across the state who work collaboratively with police departments, and when available, respond to the crisis calls with the police. And that's what you're gonna hear about. CIT training is also available to all the mobile crisis team clinicians. And right now at this point, over 50% of all clinicians across the state have been trained in CIT. Beginning in 2007, DMHAS had also contracted with NAMI Connecticut to partner with cable to provide support and outreach to police department, mental health providers, and advocates, local NAMI affiliates, to provide education on CIT and offer guidance to police officers. To date, DMHAS has funded over 70 CIT trainings attended by approximately 2,500 people, including state, municipal, hospital, university police officer, mental health professionals, correctional officers, probation officers, and EMS. There's around 116 police departments in Connecticut that now have CIT trained officers, and 43 police departments approximately that actually have a CIT policy implemented. So with further ado, I will pass it along to Sue.
Thank you, Nydia. Wow, that was very comprehensive. So I think that I'd like to first of all thank you for this opportunity to talk about such an important topic. Certainly one that's close to my heart, help instead of handcuffs. After spending 20 years working as a municipal police officer, that was always in the forefront of my mind. How often are we sending people into the criminal justice system that would be better served by the mental health system? And CIT, crisis intervention teaming, is really a resource that helps to reduce the likelihood that the criminal justice system becomes the first response. I would not do justice without talking a little bit about Cable and Cable's founder, Louise Pyers. She started Cable around 20 years ago after her family experienced a mental health related incident that involved law enforcement. And as a result of wanting to know sort of how it happened, why it happened, and really to prevent it from happening again, Louise sort of set out on a journey where she met a captain out of the New London Police Department, Ken Edwards, and they together really kind of brought CIT, or crisis intervention team training, to the state of Connecticut. Further on, partnered with DMHAS and NAMI, and that continues to grow. I think the value of a crisis intervention team is really founded in the word partnership. One of the things that I think makes it really unique is if you think about law enforcement, mental health and addiction service professionals, as well as, and most importantly, individuals with lived experience, coming together to problem solve, to create partnerships that collectively produce better outcomes for individuals. So it's not any one group individually. The strength of CIT is really in building that partnership. And when we have a healthy partnership, and they're all different throughout the state, because our state is very different. We have very rural areas, we have very urban areas. the state of Connecticut is very different. But when those partnerships come together with the resources that are available and good strategic problem solving, we know that individuals end up better off. That is actually the goal of all of the cable trainings. Are we leaving people better off? And we know that when law enforcement encounters an individual in crisis, sometimes we don't necessarily have the resources to leave them better off, but we certainly never want to leave anyone worse off. And collectively, when we come together, the opportunity with mobile crisis is not only to leave them better off in crisis, but also to give officers training and insight to identify the potential for crisis earlier, and that connection can be made to services to even prevent crisis. So CIT has been here for over 20 years. It's in various states of implementation, but is growing all the time. We have a wonderful framework here in the state of Connecticut. And I don't want to take any more time because Sergeant Fumiatti and Wanda Jofre are actually part of a crisis intervention team doing this work really effectively. And I would like to yield the rest of my time to them because I think that that's where you'll really begin to understand how this works on the street.
Thank you, Susan. Good afternoon, everyone. I'm Mike Fumiatti. I'm a sergeant with the New Haven Police Department. I'm currently assigned as the Fairhaven District Manager, which is a neighborhood in Fairhaven. But one of my other responsibilities is as the Crisis Intervention Team Coordinator. And so what that means is I facilitate the training of officers at the New Haven Police Department. And then that is one portion of it. And then that would be attending cable CIT weekly or monthly training. And then once officers are certified as CIT officers, that's kind of when their CIT journey begins. And then they go out onto the street and they use the skills that they've learned in that week-long training, now monthly Zoom training. And officers, it's fascinating to see anecdotally the difference between officers who have been trained in CIT and officers who have not been. And that comes with recognition of mental illness. That comes with better de-escalation techniques and skills. It also comes with kind of a sense of confidence in and reduced fear when interacting with individuals that are suffering from a mental health crisis. And so where that partnership continues is with Wanda Jofre and Connecticut Mental Health. So as the CIT coordinator, I look at my role as assisting officers getting trained and then encouraging them to use the techniques on the street, but then also encouraging them to build and continue forging partnerships with mental health providers. So recognizing that law enforcement officers are not clinicians or social workers, we try our best to build on the relationships that we have with other agencies. And Wanda and Connecticut Mental Health are phenomenal partners for us. And our relationship has had a history of being very productive. CIT has been embedded with the New Haven Police Department as a model for over the last 15 years. Wanda and I obviously haven't been around that long, but in the last few years, Wanda and I have really expanded the partnership, and we can go into great detail on how we do those things. If that's something that people are interested in. We can also talk about how we're constantly looking at getting better. So whether it be law enforcement officers or clinicians or social workers, we're trying to get everyone into the same room, people who are going to be responding to calls together, and talk about how to best serve the clients that the mental health professionals are dealing with. And so with that goal in mind, that's kind of where we start every interaction. What is the best way to serve this particular individual? And most of the time it's taking a deep look at what actually is going on in that person's life, whether it be support systems, and how with all the resources that all of these agencies have, how can we give this person the best chance for success in their mental health overall? Wanda, do you want to expand upon your role with us and how that works?
Sure, absolutely. So, as mentioned earlier, my name is Wanda Jofre. I'm a licensed clinical social worker out of the Connecticut Mental Health Center in New Haven. I am the CIT clinician for the New Haven and West Haven police departments. My role as a CIT clinician is a liaison role with both departments, and what the work that we do is each of the CIT coordinators and I go over all of the reports in which the officers responded to a mental health related call. Pre-COVID, I would do a ride-along once a week in each of the agencies, and a CIT trained officer and I would go back to those clients and do follow-up visits. And during that follow-up visit, we would assess kind of what happened when they went to the hospital, what was the follow-up plan, are there any barriers to that follow-up, and how can we provide any additional services or support. So sometimes what happens is, for example, they'd be referred to an intensive outpatient program, but they don't have the transportation for it. So they would, I would help connect them to that. It's been surprisingly very well received. Initially, when we knock on the door, we kind of get a oh my God, why is the police here look. But once we kind of explain why we're there, generally it's been a really well received visit. Also, when I'm writing with the officer, if a mental health related call comes in, then we would respond together so that I can do the mental health assessment. Due to COVID, obviously we're not doing the ride-alongs right now, but the partnership and the collaborations continue. Officers now, when they respond to a call, oftentimes call me to ask if I can respond with them when it's a mental health related call. If it's after hours or if it's at a time where I or none of our mobile crisis clinicians are available, then I can provide feedback and consultation to them over the phone. And we've also gotten some calls from like internal affairs and things like that when people respond there, and officers have been able to identify that maybe there's some sort of mental health symptoms. So that's kind of basically how we do our work together. It's a phenomenal collaboration. It's a phenomenal relationship. We've kind of learned to understand our roles better. To ultimately, like Sergeant Fumiatti said, advocate for the best services for our clients.
So I'm unable to unmute my or start my video, but I know that there was a question that had come up about, how has response changed over the years to individuals experiencing mental illness or in some type of crisis, or even not in crisis. And what came to mind, Mike and Wanda, maybe we could handle this question together, is how our training has changed how we've changed our training approach with CIT. And I think about, one of the introduction slides that we have is a gentleman, obviously homeless, perhaps, like sleeping on a sidewalk. And Mike, I don't know if you want to give a little context about what that looks like, or how we introduce that slide.
Yeah, absolutely. So the slide involves, and so what we're doing is we're trying to get officers to think about the other perspective. And so in the midst of a shift in which, you can go to a barking dog complaint, and then you might be going to a shots fired call, a major incident where there's a traffic accident, and then a call for a homeless person sleeping on the sidewalk. And so all of those calls involve obviously different tools and techniques and strategies when the officers are responding. And one of the calls that seems to get overlooked is the lesser of priority calls. And so when we start the presentation with a picture of an individual sleeping on the sidewalk, and we ask officers, how do you think that person feels when they hear or see you approaching? And we keep it very simple and ask them, do you think the person feels mad, glad, or sad? And in the last few trainings that we've done, the majority of officers say either mad or sad. And that's, somewhere over 70% of officers say the person does not have a positive reaction to law enforcement coming towards them. And so we talk about what their experiences, what the person's experiences with law enforcement may have been like. And generally, the idea is that they may have been negative. The person may not have liked the results when they came in contact with law enforcement. Then we ask the officer to think about what it's like to sleep on the sidewalk, why that person might be sleeping on the sidewalk. The picture takes place during the daytime. And so it's very interesting to see the perspective of officers, and then we provide the thought process for being on the other side of that interaction and the fear that comes with being approached by law enforcement officers, and the questions that might come into play. And so by looking at both sides of the spectrum and exposing officers to how a person might feel when officers approach can dramatically change the way officers approach people, because they're thinking about it from a different perspective. Something as simple as assuming that the person is sleeping on the sidewalk because or that it's a painful experience, or that they don't want to be sleeping on the sidewalk. And yet this particular individual in the photo chose to sleep during the day on that sidewalk because they were at an elevated position, and during the daytime, people don't steal your things, as an article that goes with the picture depicts. So it's interesting gaining that perspective on why that might be the safest place that person has slept in a month. And the officer might be thinking, all right, well, I just need to get rid of this call, move on to the next call because there's other calls holding and I have to make that a priority. So what we've encouraged officers to do is slow things down and try to make that connection with that person before we try to take any sort of helping action or law enforcement action. Try to hear the other person's side of the story and what's going on in their head before we move forward in that interaction.
It's interesting to me, Mike, what I hear you describing is empathy, right? Taking a non-judgmental perspective of another individual, which is really something that I think is a little bit kind of hard to teach. It's hard to experience. I think over time, when we ask in the beginning, like, what would your response be to this scenario if this was a call for service? And, we have the options of, move the person along, do a emergency committal or emergency evaluation paperwork, or actually develop a relationship with that individual. I would say over time that there was at one point, move the person along was a more common response. What we see now is that, and certainly towards the end of the training, the importance of developing a relationship with that individual so that we can help them. They invite us in to allow them to help them. And we talk a lot about that. A lot of times we do to people, but we don't do with people. And that's one of the shifts that we really try to help people make during the CIT training.
That's a great point, Susan. I think there's a couple questions I want to just address. Elaine said a couple of things. She has two in there. She asks, are you open to further training concerning disability/diversity assessment and intervention where presenters are people with disabilities and other differences? I would say absolutely. The more perspectives that we can gain, it's very beneficial for law enforcement officers to hear that perspective. I've learned so much from people with lived experience related to mental health and mental illness. And I just think that when you get that perspective, it helps you to understand where families are coming from, where people are coming from when you go to interact with them. 100%, absolutely. I'd love to talk more about that, Elaine, if you're interested. And then you also asked, why not ask if the person would be afraid? It's not the same as mad or sad. Correct. We ask mad, sad, or glad just to keep it very basic, but we talk about fear a lot, and we talk about how people are fearful of officers, and to understand that while the police officer might think that they are representing something that's positive in and that they are proud of what they're doing and they're showing up, we are trying to help officers to see the other perspective and the fear that can unfortunately come with that uniform at times.
Mike, if I could just jump in a little bit. I really appreciate that question and the involvement of others. I think it's important so Mike, Wanda, and myself and the rest of our cable training team, we facilitate our trainings on Zoom much in this fashion. And one of the members of our training team is an individual with lived experience. And so often, it's not only about just having someone come in to talk about an experience, because our Mary, who is part of our team, she's sharing her perspective. So I might be sharing a law enforcement perspective. Wanda might be sharing a clinical perspective. We are also bringing that lived experience perspective equally at every single moment throughout the entire training. So I think that's it's a little bit different, but I know I've learned so much by being together in the room, we call it, with all of the different sort of mindsets and perspectives, because that's where we find that common ground. And when we find that common ground of perspective, we know that we actually do a better job.
Susan, there's a question on the board from Jermaine. It says, is CIT training available for shelter workers? You'd probably be the best to answer that.
We have not done, to my knowledge, CIT training for shelter workers, but we certainly could. So certainly that's something that, again, if you want to reach out to me or somebody on the cable team, we'd be happy to further that discussion.
So Wanda and Mike, it's Brian. One of the questions that I have is one of the pieces of this that is often forgotten is the dispatch piece. When the call comes in and the dispatcher gets that call, what kind of training does New Haven provide to their dispatchers, and how do the dispatchers handle this?
So our dispatchers are trained, they're a separate entity from the police department. So they're not police officers, they're civilians. And so they have an extensive training on call taking and listening empathetically. So there's a basic training that they go through, but we're in the process of bringing all of them on board with CIT training as well. We have had a number of different dispatchers that are trained in CIT, and it's very interesting to gain their perspective, because oftentimes they are kind of left wondering what happens in scenarios. So they get the call from a family member who is frantic, or they get the call from a person who is in the midst of a mental health crisis and needs help. And oftentimes they aren't able to find out or see what the resolution is. So I think in bringing all pieces of the puzzle into the system and into a class together, where it be officers, security guards, I'd love to see shelter employees, dispatchers, everyone who would be responding to a crisis, into a CIT, so that they can see and gain the perspective of each different piece of the puzzle. So our dispatchers are trained in handling, taking that call from those people, and they're taught to listen kind of the same way that officers are. I would love to see them. I don't believe any of them are CIT trained, but I would love to see that happen. That's definitely something that we do very regularly in cable CIT programs.
Yeah, we have dispatchers in just about every single one of our trainings. And I think one of the things that it promotes, that cross-discipline training, is that common language. So, you know, we start to use similar words that mean the same thing to different groups, that, you know, we again, that we connect on that common ground space.
Susan, I think there's a question for you from one of the attendees. Is this training done in every town? And if not, why not?
So the training is open to all officers and in every town across the state of Connecticut. Cable is a statewide organization. So it's to whatever degree the individual towns choose to send officers for training. We know that capacity and funding is always somewhat of an issue. We have worked very diligently at Cable to adapt, even in COVID, to move the training online so that it's much more flexible, so that we're able to better adapt into meeting each department's needs. And I know that the departments that do send officers, they do see a difference. They see a difference in the response. They see a difference in the outcome and the relationships that they build within their communities.
And Mike, there's another question from an attendee that asks, do officers do anything to change their appearance to be more approachable when responding to calls about folks experiencing homelessness, i.e. leaving their gun in the car, not wearing all their arresting gear? And if so, do you see more positive interactions this way?
So the first part of the question, officers don't change their appearance. They would take whatever equipment they have on them to every call. So I think the second part of that is, though, understanding that officers can't leave those things behind just by our policies and et cetera. What we do is encourage officers to give the person more space. We encourage them to use more pausing rather than taking control of a situation, which might be taking physical control or asserting their authority. We encourage them to kind of check the person's behavior first and kind of get a feel for how the person might be going through a crisis before they inject themselves into that person's story. And so while they still have all the equipment with them, I think that the approach that understanding that we can't change the equipment specifically for each department, that would be an individual policy for that department. But what we can do is change the way officers approach people and help them to be more empathetic and to use some emotional labeling and use increased distance so that we're not adding fuel to a fire that's already going. We're trying to de-escalate that situation. There are agencies across the country that do things like that, that do have officers. I don't know of any that send officers without firearms, but they do sometimes send officers in softer gear, whether it be not the traditional law enforcement uniform. And they do have some success with that. That's an issue with policies and procedures kind of from state to state and department to department, and then also funding. This is not a specific team. So it's not, while it's called a crisis intervention team, these officers are officers and detectives and sergeants and lieutenants that are doing their normal roles. And then when a crisis call comes in, they would be the ones to respond to those calls. So they could go from, like I said, a parking complaint or a barking dog complaint to a mental health crisis call. It's not specifically just for a mental health crisis call in New Haven, at least, and generally around Connecticut. I don't believe there's any place that specifically have officers assigned to a team like that.
And we have another question from an attendee that asks, what kind of implicit bias training occurs?
Well, I can answer that very proudly, actually, because yesterday we launched our first iteration of community interaction training for law enforcement, which is exactly focused using the CIT, crisis intervention team, sort of skill and model to implicit biases, explicit biases, and we did a 4-hour training, which we will be doing every other month as well. So we included a little bit, but we're also we have a concentrated focus on that because we have a phrase in CIT training, you know, writing someone else's story. And how often do we do that based on not only implicit but explicit bias? That we know somebody else's story before we've actually developed enough of a relationship with them to learn their story.
And Wanda and Mike, we have a question. Do police have the ability to bring people to shelter if needed? What if somebody needs to go to a different town?
Sorry, I was just trying to unmute myself. So it depends on town by town, city by city, and it also depends on how far. So it's kind of our policies. Yes, we are. In some jurisdictions, you are able to bring that person to a shelter. So in New Haven, yes, with a supervisor's approval, an officer can do that. If the person had to go to a different town, it's also kind of up to a supervisor's approval at that point, depending upon a lot of different things going on in the jurisdiction at the time. A neighboring town, generally, that's not something that would be turned down. But yeah, we found that sometimes the barrier is transportation. I'm sure all of you that work with homeless populations or individuals suffering with homelessness, a barrier to treatment, services, housing is just the ability to be moved around. So transportation becomes a big issue there. In working with different homeless outreach groups and the Columbus House and agencies around New Haven, we've seen that if the officers can help in that way and someone doesn't mind being transported in a police car, I'm all for it. I think if the best thing that we can do is if we can get somebody into the services for that first step, if that might be the most impactful thing that a law enforcement officer could do in that person's lives. And, certainly that doesn't involve handcuffs.
So we have a couple more questions. The first one is, are all officers required to take the training? And I know we're at 3:54, so we have about 3 minutes. Then we have, I think, a great question, and it's, how do we measure success?
So are officers required to take the training? No. There is required yearly de-escalation training. There's required now in the academy mental health first aid and awareness training. But those, other than those initial ongoing training or CIT training is not required. And although I think it should be. And how do you measure success? I'm not sure exactly. I might need clarification on that. Success for, I think for us personally, for me personally, if I don't want to speak for Wanda, but if we can help someone who's in a crisis and we can avoid any sort of physical confrontation or violence, and we can get the person to whatever resources they need. I look at myself and other officers as just being the safety. We are essentially maintaining safety while hopefully clinicians can do, it is what they do best. And so our concern there becomes the safety of everyone involved. And so I think a success is just getting that person the resources they need safely.
Absolutely, and if I may add, this is Nydia. I just wanted to add, obviously, there are ways that we collect data and information. That's how I gave you some numbers at the beginning of the description in terms of referral source. So if it's the police who's calling the mobile crisis team, for a CIT call, and obviously the disposition that happens and the outcome measures that we currently use. So we have some information and data that we collect, but I know, Wanda, you wanted to add to that.
Yes, I just wanted to kind of reiterate what Sergeant Fumiatti had said, and it's definitely if if we can make the difference for one person, even if it's changing kind of their perspective of their idea of what a co-response should be like. Quickly, we had a call actually on Monday where the mom of the client was really reluctant to having police on site. However, there was a safety issue because the client had earlier in the morning threatened his sister with a knife. So I kind of said, we wouldn't be able to respond to the call without police, and we made a plan that police would stand by. It turned into a crisis negotiation response several hours later, and the client did get the help that he needed, and mom was just really grateful for that. So that's how relatively relationship-wise I consider success.
So we are at 3:57, which means we have to wrap up. I want to thank all of the panelists. This was really, I think you guys did an awesome job. You certainly made my job easy. And I'm going to hand this back over. I want to thank the Connecticut Coalition to End Homelessness and of course DMHAS for sponsoring this workshop. And I'm going to hand this back over to Madeline, who's going to close us out. Thank you, Madeline.
Thank you all. I just want to note that there are 70 people here on a Friday afternoon, so I think this was a really much needed, valuable workshop, and we're really grateful to all of our presenters for spending your Friday afternoon with us, educating everybody about what you're doing. So this is great. Thank you so much, and thank you to everybody. This has been an amazing ATI. We have had over 1,000 people part of this wonderful event over the course of the week. We do have a happy hour coming up next, so we hope that everybody who's here will join us for the happy hour. It's been wonderful to hear people sit back and relax and talk about what they have learned from each other and just be together. So thank you again to all of you, and have a wonderful weekend.